I'm presenting the title is Deciding the PCI Strategy in Acute Coronary Syndrome with High Thrombus Burden and Complex Coronary Anatomy. This is a case presentation. Myself, Dr. Shishir Soni from AIIMS Rishikesh. Disclosures are none and there is no conflict of interest. My co-authors are Dr. Bhanu Dugal ma'am and Dr. Vijay Kumar Bada. Both are from AIIMS Rishikesh. Clinical information: a 48-year-old male was known diabetic for 8 years and hypertensive and had history of tobacco chewing. Presented with chest pain for 19 hours. He had shortness of breath for last 4 to 6 hours. The ECG was done, which was suggestive of ST elevation in V1 to V5, and the echo was done, screening echo was done at the emergency, which was suggestive of anterior and anteroseptal hypokinesia with LVF of around 35 to 40%. He was COVID rapid antigen test positive, and his vitals were 90 by 60 millimeter of mercury. But while shifting to the cath lab, he had some drop to 88, and NORAD was started at a very low dose. His pulse was 88 per minute, and respiratory rate was around 20 to 22 minutes per minute, and SpO2 was 97% at room air. So the timeline was that he had chest pain and followed by shortness of breath and presented at 19th hour of the chest pain at this center. And his ECG was suggestive of entry of all ST elevated MI, and therefore after loading with the aspirin ticagrelor, he was immediately shifted to the cath lab. In the cath lab, CAG was done, and it was as shown in this fluoroscopy angiogram. It is suggestive of distal left main plaquing, followed by proximal LAD 100% occluded with thrombus. In the spider also, that is showing the same finding. However, there were no other significant findings in the RC and LCX except the OM, which was a smaller one. Then the procedural steps, the major challenges in this scenario was that this case was ACS and STEMI, and the lesion as per se that proximal LAD was completely occluded, and thrombus containing as shown in this figure that there was distal left main plaquing with two other major branches, ramus intermedius and LCX, which was equally important, and then the LAD which we have to salvage. And it was a thrombus containing lesion. So another one was distal left main plaquing and increased risk of thrombus dislodgement in LCX and ramus intermedius during hardware manipulation. And another thing was the time limit and other thrombus related challenges that we all know that increases the clinical outcome during and post intervention. And the thrombus especially increases the intervention related risk of distal embolization and stroke risk and other things that we all know. So procedural step that early establishment of the flow was the main strategy and avoiding the complications of by managing the thrombus. And here we used just passing the guide wire and the balloon, and we proceeded for the PTCA to LAD with JL 3.5 to 6 French guiding catheter was used, and lesion was initially attempted with Xion blue wire. However, it could not be crossed, and then with the balloon support we attempted. Finally, the lesion was crossed with the filter FC wire, and the pre-dilatation was done with 1.25 into 10 mm balloon followed by 2 into 15 mm balloon. And as shown in this video, that the flow has been established, although there was some slow flow. Post-dilatation, this was the results that flow has been established, but as we can see that there is some challenges. So what next? As we know in this diagram that the distal left main plaquing was there, and proximal LAD that we have balloon dilated, and other vessels are also there. So available options are IVUS to LAD to left main, and another option can be stenting of the LAD lesion only and followed by intravascular imaging later on at a later stage. And there can be stenting from left main to LAD. So what we preferred was the stenting of the LAD segment lesion only followed by intravascular imaging of the left main later stage. So that was our plan, and 3.5 into 40 mm drug eluting stent was that segment was stented to the LAD from proximal to mid LAD. However, as shown in this by this arrow, that after stent deployment there was some thrombus, as you can see by the all three views that we have taken. So again, what can be the next? The available options that we could consider in these situations are GP2B3 inhibitors we can give, and continuing the anticoagulation only, as there distally the flow was well established and there was no uneventful procedure. Another can be the thrombus aspiration, which is again a questionable thing. So we did what that we started on tiotropium infusion, and after giving 100 ml of tiotropium infusion, we stopped infusion and then we continued heparin infusion for 48 hours, and patient improved symptomatically and further stay was uneventful. Although the patient could not turn up for the IVAS because of a financial constraint, but we have actually planned for the IVAS to the left main. But patient remained asymptomatic and he improved and was successfully discharged. So I'm concluding that the PCI in ACS offers many challenges, especially for the beginners, and where fate may be somewhere between the uneventful procedure and a nightmare, which we all want to avoid. However, establishing the T3 flow in the culprit vessel as early as possible is the ultimate aim. Where deciding the PCI strategy is the critical step to deal with complex anatomy. Thrombus-related complications can still be encountered at any point of time, as we have seen in this case also, that we try to avoid at every step that such complications should be avoided. However, at the end, we ultimately after stent deployment, we still have found that small thrombus over there. So that has thrombus-related complication can be encountered at any point of time and has to be dealt with very carefully to avoid the complications.
Dealing with a almost osteoality acute occlusions, there is a lot of thrombus, and if one is not careful, one can actually make the things very complex, you know. So even the smaller motions of wire and balloon up and down the vessel can break a lot of thrombus particles, and it can go anywhere into the circumflex or AIIMS and make the things very complex. So that way, these are the tricky things, and you manage it quite well. I'm pretty happy. These thrombus protrusions can happen whenever there is a large chunk of thrombus in any artery. You stent it. It's like a cheese grating effect, you know. So it is quite common and usually best managed by balloon inflations, not at very high pressures. If you make it a high pressure inflation of the balloon inside the stent again, the cheese grating effect would actually become more enhanced and more pronounced. So it should be a balloon inflation at a very low pressures, 2 to 4 up to 6 atmospheres, not beyond that. But then balloon should be almost the vessel size, 1:1. So that is the best way to manage it. And obviously, yes, GP2B3A inhibitors, uh, can be used to further decrease the thrombus burden. So it is very well managed.